So I would like to speak about Lille experience. I'm so sorry, I'm not talking about the number of patients and the incidence of CRS, or neurological toxicity, etc. You've been listening and hearing this throughout the 2 days. So my talk it's going to be about the organization of the activity of CAR T cells in our hospitals, especially from clinical standpoint. So we decided to locate the activity in the bone marrow transplantation units because, as you know, we cannot limit the toxicity of CAR T cells to CRS and neurological toxicity. They are a really need for full management of those patients. So I will go through with my slides. Just some numbers for our hospital. So the Lille University Hospital belongs to the largest university campus in Europe, which is spread over 350 hectares. And we have 14 buildings, 300 beds roughly in our hospital, and 16,000 employees, including roughly 4,000 doctors. For the hematology department for adults, because we have adult and pediatrics, we have 73 beds, including 20 highly protected beds and 10 pre- and post-transplant unit. So this unit, we don't have air filtered, but we have a good ratio nurse and patient. In the day, we have 1 nurse for 3 patients, which is a good number for doing CAR T cells, for instance. We are performing 100 allogeneic hematopoietic cell transplantation per year. We have 50 beds in the general ICU and 16 beds in the general surgery and other beds for the ICU for some specialty such as cardiac surgery, etc. So the origin of patients, actually, there are 10 hematologic departments in the Hauts-de-France. This is the region, the big region. Actually, if we exclude Amiens, they have their own allogeneic transplantation unit. So Lille is the only authorized centers in the region to do allogeneic transplantation. So our region count 4 million inhabitants. So for the organization, we decided just right now to have the industrial and academic protocols, and we started commercial CAR T-D. So our organization were based on the recommendation of the French Society of Bone Marrow Transplantation and Cellular Therapy. So first of all, our colleague can send the patient to our referral doctors. We have specialists in lymphoma, myeloma, MDS, ALL, etc. So the role of those referral doctors or physician is to identify patients and to make the decision for CAR T cells. Then they send the patient to our unit so we can confirm the indication, and we really need to confirm the feasibility of such a treatment, and then we can issue some sort of agenda for all date for the patient. Of course, we are helped with many specialists. It was very easy to have them because they were already working with us for allogeneic patients. And it's maybe special for Lille when we have a CAR T candidate, so we look right away to the HLA and we try to find a donor, even if we don't need to go to further allogeneic transplantation. But this can be useful if sometimes you can't do CAR T and you have to switch. It's happened for one of our patients. And we could transplant her, and the same day the CAR T was scheduled. Then we send the patient after some lab tests to the apheresis facility. The apheresis facility will send the product for the production facility. After that, we sent the patient back to the referred patient for the bridging therapy or taking care of the patient because there is something like 4 to 8 weeks between the first time we see the patient and the day we infuse CAR T cells. So the patient need to be followed by the expert for the disease. Then when the product arrived to the pharmacy, the patient is hospitalized to start the conditioning, lymphodepletion conditioning. Our pharmacy is equipped with the storage room and manipulation facility if needed. Then, for the first period, we have a close collaboration with our ICU unit. So this is the journey of a patient CAR T coming to Lille. So this first period, it's very difficult because we are dealing with patients with progressive disease, so there is some rush or urgency, so we have to take care of the patient to decide everything, and we need really a good collaboration with the coordinator, secretary, and doctors, and even data management. Then, when the patient is hospitalized, so we decide to keep them 14 days after the infusion of CAR T cells. Why 14 days? Because unfortunately we can't use the Seattle manner to treat this patient, so we can't send them back to their home because we cannot be able to have beds ready for them just in case. So for our organization, we decide to keep them 2 weeks. And if the patient develops some complication needing ICU, we can transfer them to ICU. And in the just event the patient develop a profound cytopenia, we can transfer them to our highly controlled unit. Actually, we have our procedures for all complications, such as here an example for the CRS, and this is for neurological complications. We are based on the recommendation of the SFGMTC. Now, when the patient leave at discharge, so if the patient leave within 30 minutes from the hospital, they can go home. Otherwise, we keep them in a family house just near to the hospital. This is our building. It's a very nice hospital, and this is the family house for 2 more weeks. Then the patient will be followed in our long-term follow-up. At the beginning, we need to see them once a week, twice a week, once every 2 weeks, etc. So we get exactly the same procedure for allogeneic transplant patient, because those patients can develop some complication, especially viral or infection, and we need to supplement them, etc. And then we follow up them in our long-term follow-up unit. All our patient data are entered in the EBMT database, because I would like to remind you that we need to follow them 15 years. This is the law. So what about the accreditation? Actually, our unit is JC accredited, and we renewed the accreditation in 2016. We would like to be JC accredited for immune effector cells when it's possible. We get the agreement from the KITE for commercially Yescarta, and we started using Yescarta, and we are waiting for some signature, I hope hopefully with Kymrea. Of course, before starting, we developed a training program, because really you need to train your nurses, the doctors, fellowship, and intensivist, neurologist, data manager, and pharmacist, etc. And we have organized 3 international meetings in Lille, so to complete the training of our staff and others, of course. So for our activity, we started in July 2018 with the first infusion in September 3rd. For multiple myeloma, we had industrial BCMA, phase 2, which terminated. We included 4 patients. We are part of the Karamba consortium, as Michael said. And industrial BCMA phase 1 and 2 are about to open. And we hope to be part for the second phase of Karamba consortium to be able to produce locally the CAR-T. And for indolent lymphoma, we have 2 protocols, 1 open. We have already included 2 patients and 2 are underway. And the other protocol will open shortly. And for DLBCL, we have phase 2 ongoing, so we already infused 1 patient, and another phase 3 will open in March. And Yescarta, we already collected 6 patients and infused 2 of them, and we are waiting for the agreement for Kymriah. For ALL, we hope to be able to have an academic protocol later this year or early next year, and Kymriah after the agreement. So, to sum up, in 6 months, we got at least 20 patients referred and 2 underway. I have just received the email from my colleagues, and we have collected 14 patients, including 1 patient 2 times for difficulty of production. Already infused 8 patients, and we denied the indication for 4 patients, So not every referred patient can get CAR-T cells. So in 2019, we'll cover almost all indication in this available this time. So for my conclusion, management of patient undergoing CAR-T cells requires 2 mandatory conditions. First of all, a well-structured clinical unit with well-established procedure to take in charge patient developing acute immunological and long-term complication or follow-up, and of course, an intensive care unit. Thank you very much. This is my colleague. I'm so sorry, all female didn't want to come with us for the photo. So there are some color missing here.